So yeah, my name's Marshall. I was born in the Twin Cities in Minnesota and mostly grew up in Amiskwetsi-Waskagan in Treaty 6. It's also known as Edmonton, Alberta. My education background, for my undergrad, I did a honors degree in Native Studies at the Faculty of Native Studies at the University of Alberta, which is the only autonomous Indigenous faculty in North America. And there I really focused on doing research for Aboriginal and treaty rights cases, specifically kind of looking at land rights and hunting rights a lot, and have done a lot of work in that field kind of before transitioning to the health realm. And then I went on to the University of Toronto to do my master's in social work and public health. Well, I had been living in Coast Salish territory, Vancouver, for a couple years, and I was working at the First Nations Health Authority, and I was traveling a lot to communities all over the province for work. And to be honest, as that was such an amazing learning experience, and I got to learn so much from nations and leaders all across BC, but the travel got kind of tiring. So I saw this opportunity come up at the center, and specifically the co-directors, Martin Schechter and Nadine Caron. I'd kind of been a little bit aware of some of the work and advocacy that they've been doing throughout their careers. So it seemed like a really good opportunity, a good fit. I kind of felt ready to maybe reinsert myself into an academic environment. And the specific job posting was to create new Indigenous health programs here at UBC. And I was kind of fueled by some of the negative and infuriating experiences I had at U of T, and the lack of relevant Indigenous health curriculum that I experienced in my graduate studies there. And that experience kind of motivated me to take on this role where it's really centered around creating new courses, creating new programs, and creating a space for curriculum and Indigenous students or people working in the realm of Indigenous health that's relevant to them. Because so much curriculum in terms of being an allied health professional or working in Indigenous public health, a lot of the dominant curriculum, it's just not relevant, and it's not relevant to the places and environments that people want to be working in. So my job's mostly around trying to create those new programs, and we're kind of well on our way to that. I guess right off the bat, it was mostly because it was so juxtaposed with my undergraduate degree, where it was mostly First Nations people, Cree people from Treaty 6, as well as across Canada. And there was a huge range of age demographic, of class, of background. And the people in the classroom had so much experiential knowledge, and they brought that in with them. And when I went to University of Toronto, where tuition's more expensive, there's more barriers, it really was switched to being a predominantly white classroom and people from wealthier backgrounds. So automatically it kind of took away a lot of that experiential knowledge. And then additionally, people were so clinically focused and so focused on the medical model, because that's where a lot of the jobs and money and funding are, that there really wasn't a space for, Indigenous curriculum. And I was even kind of shocked at how little faculty knew and how little they attempted to incorporate it in respectful ways. And, myself, along with some other students, kind of did whatever we could to advocate for changes, and there certainly has been some. But yeah, it was definitely quite challenging. Anytime an Indigenous topic got brought up in class, everyone would kind of look to me. And it's also challenging when I'm going there to try and learn myself. And, I have so much more experience than even the people who are teaching or speaking to the issues a lot of the time. So just removing that experiential knowledge, I think, has a big impact. And even if I was taking a quantitative analysis or biostatistics class, the statistics that are available for Indigenous populations versus non-Indigenous populations are so vastly different. The politics and the way those things are governed is so vastly different that a lot of the time the curriculum that was being taught just really wasn't relevant or useful to the situations I knew I was going to be working in. And I kind of found that to be quite frustrating. Right. So I mostly grew up in urban setting, but I have a lot of family. My mom was born and raised in Yellowknife in the Northwest Territories, and I have a lot of family in Kugaruk and Talakwarak in the Kitikmeot region of Nunavut. And they definitely face a lot of massive barriers in terms of the way the health system and healthcare system is structured to serve them. Often in Canada we kind of fall to this meme of having a universal healthcare system that has equal access for everyone. And if you really start to look at the details and start to look at health outcomes and services for different populations, you kind of realize that that is absolutely a fallacy. And we often compare and contrast ourselves with the US when really we should be holding ourselves up to a much higher standard. And I think recently I was talking to a family physician in Sioux Lookout, Dr. Mike Curlow, who's been in the news doing some advocacy lately, and he kind of has definitely shaped some of my thinking in terms of talking about the healthcare system for Indigenous communities, especially in remote communities in Canada, by saying the system's actually functioning the way it's supposed to, and it's supposed to deny care. It's a system designed around denying people in remote communities care. And you definitely see that in my own experiences with my own family. Like just over Christmas, I had a relative from Kugaruk who had to come down to Edmonton, all the way from Kugaruk to Edmonton, just to get an ultrasound. Having to make huge trips and be away from family and community and be isolated, just for very simple procedures. And you can see that across an absolute plethora of health conditions and services needed, that the people who live in remote communities, the system is designed to deny them care. And it's also designed for them to not necessarily be in control of their health systems and solutions. And we really need to change course on that. Yeah, so I mean, a lot of it is just to do with the control. So when you're in a remote community, obviously the cost of receiving care is much higher because generally the services aren't located in the communities themselves. And that means that you have to apply to the FNIB, the First Nations and Inuit Health Branch, to approve your travel to go to an urban center or a catchment like a Prince George or a Sioux Lookout that services all these remote communities in order to receive that care. And the people who are making those approvals are generally not from the community. And the health system at large hasn't done a good enough job of doing everything they can to train people to effectively give services in the community, or to advocate for having people from the communities themselves actually be funded to train and trained to provide those services themselves. So really it centers around people having to travel, get approved to travel to urban areas for really simple things. And oftentimes when people need sustained care, if they have some sort of chronic condition or they need sustained care for their child, they have to move away from their communities in order to receive that care. The ideas and perspectives and philosophies around traditional care certainly aren't monolithic, and it would differ from every community and every elder and every individual. So I think really the focus there needs to be on just listening to people and understanding that it is a constitutional right that communities and Indigenous people have to receive care from their own practices and the perspective of their leaders and their elders. And the system certainly hasn't done enough of a job of listening to and providing adequate space to incorporate that in. But even in terms of me speaking to what that is for certain people, like I certainly don't have that authority, nor does anyone really. I think you have to allow people to be self-determining in that, and then also open up pathways for them to access and utilize those forms of treatment and care, because we do know that they're effective. Like We know from experience, we know from stories, we know from oral traditions and histories, and we do also know from research that, non-Western forms of receiving medical care and treatment can be quite effective. Yeah, I guess I would see it working in a way where the resources are available and the doors are open. So, there's lots of Indigenous people who really do want Western, medical care for themselves, and it's what is most effective for, their recovery and their healing with whatever they're going through. And then there's other people where they don't find those modes of treatment effective. So you really need to, under the current system, even if you're wanting to listen to someone and place the power in their hands, there isn't necessarily the effective pathways for them to receive alternative options. I think we can even all think of our own experiences going into a health center or going into an emergency room and having an interaction with a clinician talking about your symptoms, and then they very quickly prescribe a drug. Very often they're not asking further lifestyle questions, or looking at nutrition. What are you eating? All of these other things that very much influence our health and well-being. There's not really much room in the current system. There tends to be, quick to draw out the prescription pad versus looking at other aspects. So, those are certainly systemic issues that I think are beyond my experience and knowledge in terms of how a solution should be envisioned. But there certainly are people out there that have those ideas and do have that knowledge. And yeah, it's just about having, a more balanced approach. I would definitely think there should be more localized control of FNIB decision. Like, there's communities have, just common knowledge that you have to fight and battle the FNIB approval system, and that you have to fight to advocate for yourself, and that often healthcare providers will try and get you to use an alternative method of insurance, even though you have a constitutionally protected right to receive FNIB medical services. So I think that especially for remote communities, the communities should have more control over the decisions regarding when people are allowed to travel for medical services and when not. And they should certainly be provided more resources. And starting from the beginning, this starts early on in the education system. And there's so many barriers and so many things are done to prevent there being, an ultrasound technician, an x-ray technician, speech therapist, an MD, pediatrician in all of these communities that lives in the communities and is part of the communities. There's so many barriers in terms of the education system and the access to post-secondary that creates the situation where people need to travel away to receive medical care. And I think all of those things need to be addressed. And, really, we're just at the very, very, very beginning of starting to, open those doors and open those pathways, even in post-secondary institutions. So I definitely start to see a lot of positive changes right now, but there's a long way to go. And I think that, certainly the power needs to be put more in the hands of communities, and there needs to be more self-determination around healthcare systems and healthcare solutions. And in BC, we're certainly starting to see that with the First Nations Health Authority, being the only province-wide self-determining health authority, Indigenous controlled and Indigenous run in Canada. And I think we'll start to see in the years and decades to come a lot of positive changes coming out from that. Yeah, I mean, we know from research that Indigenous people face discrimination and racism within the healthcare system. Like, that is unequivocal, because allied health professionals, nurses, doctors are often going to reflect the attitudes of Canadian society. And we know at large that Canadian society is still very much racist. And you see that play out in terms of clinical interactions. And you see Indigenous people, we know from research that they have longer wait times, that people are often not going to receive care or not going to go to the hospital because they don't want to be treated in a disrespectful way, and they don't want to be discriminated against. So they avoid care until the issues become severe enough that they find themselves in an emergency room. So we know these things, and we need to, you can't really separate the healthcare system from the attitudes and perspectives of Canadian society as a whole. So, we need to look to the leadership, and we need to look to things like the calls to action from the Truth and Reconciliation Commission. And, all of us, whether or not we're in healthcare or not, need to take up the responsibility of seeing those things implemented. And we still really haven't finished the truth aspect of truth and reconciliation. There's still a lot of realms of Canadian society that that don't believe the truth. And I think we see that in terms of legal cases coming out right now in Saskatchewan and Manitoba. We still see these really grave injustices, and we still see a inability of Canadian society to, accept the truth and the realities of Indigenous life in this country. And I hope that we can continue looking to our elders and looking to our leaders to begin to have that truth be more widely acknowledged. And then hopefully from that, we can see things like the more effective implementation and internalization of the calls to action from the Truth and Reconciliation Commission. One thing that I often think is disconnected and not discussed in medical or public health senses is the issue of land rights and rights to resources. Oftentimes when we look at Indigenous poverty or First Nations poverty, we're so often bombarded by negative headlines that we begin to internalize that, as Indigenous issues, when really these are issues about the relationship between the Canadian state and Indigenous peoples living in what's now called Canada. And Arthur Manuel, who was a great Indigenous advocate and leader who recently passed away, the late Arthur Manuel, he always said that it's actually quite simple. You often hear people repeat the quote, "Oh, it's really complicated. Healthcare is really complicated. Child welfare is really complicated. Post-secondary issues, education issues are really complicated." And, he always said that's actually, sometimes these things are quite simple. Like, First Nations reserve lands make up 0.2% of the Canadian landmass. And yet in the Indigenous population is, roughly 5%. So that kind of explains everything to me. Canada is a resource-based economy, and Indigenous people have only been left with 0.2% of their lands and their resources. And you see that play out in every possible social determinant of health. Yet I find within public health contexts, often issues of land rights and rights to resources are isolated, and viewed as too political, and the medical system doesn't really want to take responsibility and realize how strongly those two things are connected. And, I strongly believe that unless Indigenous rights and Aboriginal and treaty rights to lands and resources are upheld, that we'll continue to see these medical issues. And, Canadians also need to realize that those rights aren't just for Indigenous peoples. Those are enshrined in the Canadian Constitution, and as settlers or as non-Indigenous people, those are rights that you need to respect also. And everyone should be involved in advocating for those to be upheld and uplifted. And really, Canada itself hasn't done a good job of upholding its own laws, and you just kind of see that come to a head time and time again.